What's the question?
No, like, how would you describe the rhythm, the scapulothoracic rhythm?
How would I describe scapulohumeral
Is it 2-1 ratio? 2-1 ratio. Yeah, but what is that?
scapulohumeral rhythm?
Degrees of humeral.
Okay, scapulohumeral rhythm is, the definition of it is for every 2 degrees of humeral movement, the scapula moves 1. That's the definition. Now what that means is that the scapula starts to move, and depending on who you read, sometimes some people say the scapula moves at 60 degrees, some up flexion, shoulder flexion. Some people say it moves at 30 degrees. That's not the important thing. It means that we have about 60 or 30 degrees of pure glenohumeral movement before the scapula starts to kick in. When we get to the end of the range of the motion, and also eccentrically and concentrically, as we come up and come down, the scapula moves with the humerus in a 2-to-1 ratio. So altogether, the scapula moves for a total of 60 degrees through the range of motion, and the humerus moves for 120 degrees through the range of motion to make up the 180 degrees of range of motion.
It sounds like the pronoun was 80 degrees, like if you kind of divide it by whatever and stuff, like...
Well, remember we said the other day that if you don't have the serratus or you don't have any of these muscles that promote upward rotation, that we can only raise the humerus to 120 degrees because I can't go up any higher if my scapula won't let me move. Right? Okay. So that's what it means. That's okay? Right. Okay. Now, Anita, can I see you? Can you take that shirt off? Now, Adeline, you can see my screen, right? Because I'm sharing my screen. I know you can't see the demonstration, but that's okay as long as you can see the screen. Okay. Guys, ladies and gentlemen, if I hold, here's her scapula, and if I hold or stabilize this scapula, okay, I'm going to stabilize it as much as I can. Okay, now I want you to raise your arm.
Forward?
Yes. Okay. That's, here, look at her from the, can you see, I can't bend down, guys, so. Can you see her from this, is it best from the side or from the front or from
From the side.
From the side, okay. So I'm going to hold her, and you watch her arm. She's going to go into flexion. All right, so go into flexion. Keep going. Keep going. No, now her scapula starts to move. You don't have a sports bra on.
No.
Want me to pop my shirt on?
No, because I don't want to touch you. Okay. Go ahead. That's about as much as she's going to go. She can tell you.
Yeah, it doesn't go anymore.
All right. So at 60 degrees, it's starting to move, but I can't stay. Go ahead. Can you move any further?
No.
Okay. So do you
Not
see
without
that's
moving.
about 60 degrees of flexion? Scapula, I wouldn't allow the scapula to move. And I'm trying really hard. I'm out of breath. Trying really hard not to move that scapula, but it wants to move because it moves to get shoulder flexion. But that was a demonstration to show that in order for you to get full scapulohumeral rhythm, or to demonstrate that the scapula starts moving at about 30 or 60 degrees. In her case, it was about 50 degrees it started to move. If she'd had her shirt off, and if I could touch everybody, and we could do this in class, we could demo this. But I want you to try this with your significant others, or people you live with, or your dog or your cat, or somebody. Huh?
Random stranger.
Just
Not
on
a-
the street? Yeah,
Okay?
no, come here.
Because you will see, and it's really hard to stabilize that scapula, but especially in somebody who you could see the scapula and it's very visible. I mean, I do it with everybody. You do it with really muscular people too. I think you have a problem with it. You don't have good, which would be wonderful to see because your upper rotation stinks. But I think that if you see it and if you feel it, you'll kind of get. Remember, I said a lot of what we do is observation. We watch people. I'm gonna see if I can get some demos of real people raising their arm up and bringing it down. Because when you raise your arm up, you need to have that movement of the scapula. When you bring it down, the scapula needs to hold, and relax. Sometimes you see this. And do you ever notice that? I mean, I bet you have it. I bet you have it too. I think you're freaky like that too. I would, and maybe we'll take a look. Maybe we'll take a look and we'll video you. Yeah.
Would this be due to downward rotator weakness, like say the levator or the rhomboids?
No, it's timing. It's a timing issue.
Okay.
It doesn't have to be weak. You as a personal trainer, right,
Yeah.
may look at things a little bit differently. Do you ever look at timing issues?
Like people say if they're doing like say deadlift, they'll extend their back before they. But
Are you
I
talking
like.
about like motor planning?
Like their hip
But
thrust.
they'll do something before the actual motion, like before it occurs. So like I'll just say deadlifting, as much as that's a bad example. I see people extend their back before they go through full hip and knee extension.
Yes.
Yeah, would that be an example of that, like a timing issue?
No.
No. Okay.
No, that would not be a timing issue. That would be a substitution issue.
Okay.
Yeah, but I understand what you're saying. I understand what you're saying. But that's why I'm saying a lot, and I'm sure there are a lot of people out there who look at this, but when we look at these movement patterns, we look to see if we have a timing problem, because anything concentric has to be eccentric when you do movement, right? So if it's moving appropriately in an upward direction, when it comes down, is it equally holding and stabilizing? Can it be a weakness? Yes. But can it just be a movement pattern issue? You've been doing it all your life. Well, not all your life, but you got into some bad pattern, you started to do it, and now all of a sudden it's just normal for you. So it's just a retraining, if you will. And one of the things we do a lot of is quadruped rocking, to just watch where the scapula is going, I mean, years ago, they used to do that with neurodevelopmental techniques, but now it's coming back because we really want to see, is that scapula moving appropriately? And sometimes it's just me holding a patient and saying, okay, release it, don't release it that fast, release, and then you getting in your brain, oh, that's what it's supposed to feel like. Low traps, you guys probably don't even know where your low traps are. I mean, you know now, right? T6 to 12, yes, spinous processes. And where do they go? Spine of the scapula, right? So you know they go this way. So what does the low trap do? Depress. It also helps with the middle trap adduct. So depress your scapula on its own and pull into that angle of where it's happening. A lot of you guys are going to do this and use lats, but just use that muscle. If I were to work with a patient, I would do a lot of tapping on that muscle and have you activate it. Then I'd have you do it in a side-lying position, and then I'd have you do it against gravity, because I bet a lot of you don't even know where that is and don't have the strength of the low trap, which is a problem with what? Upward rotation. So, this is all coming together, no, because you can have an impingement because you don't have upward rotation, not just because you have some kind of a bursitis or something here, which is a secondary impingement, which we'll talk about today. Okay, so we know the rotator cuff muscles,
There's a question. Downward.
I'm sorry?
There's a question.
Ari, yes.
What would scapular downward rotation syndrome be?
What's scapular downward rotation syndrome? Syndrome?
Scapular downward rotation syndrome?
Scapular downward rotation syndrome?
Yeah. No?
I've never heard scapular downward rotation syndrome?
Is that weighing the scapula?
You mean was it a test question you thought?
No, I was just wondering, because when you were doing with the scapula, I was wondering if it doesn't downwardly rotate.
Oh, well, no. anything that goes up has to come down, right?
Right.
So it's not really a syndrome, it's just that something, whatever's attached to it is not working properly. Or that there is it could be, as Casey said, a strength issue, but it could be a timing issue. So they're two different things. What do you do if it's a strength issue? You strengthen what's weak. What do you do if it's a length issue? You lengthen what's short, right? What if you do is a timing issue? That's different. Proprioceptively, yes? Yeah, so then you have to really show somebody what it is and feel it, and let them feel it, right? I'm a very proprioceptive person. There are a lot of people who are very visual learners, people who are auditory learners. If you, and some of you may be the same, if you wanted to learn how to type, could you watch a video on typing? Some of you could. It wouldn't work for me. You have to put my fingers on the keyboard and I would have to do that. But we're all learned differently. And some people, and most people that have these timing issues, they need to feel it. You know, they don't need to go to the gym and do this. You know, or do push-up plus. Doesn't do it. Not for a real timing problem. Okay, yes.
So for the scapulohumeral rhythm, you're talking more about the movement of the humerus and then the scapula, not the surfaces? It's the bones?
Correct. It's the bones. It's the bones. Scapulohumeral rhythm, we're talking about two different joints. We're talking about the scapulothoracic joint and we're talking about the glenohumeral joint.
Right, but in terms of degrees of motion...
Don't get caught up on
it's
degrees.
it's probably
If you could read 10 different articles and you're going to have 10 different explanations. It's basically the scapula and the scapula and the humerus move together and they all agree. Anywhere you look, will agree that there's a 2-to-1 ratio. Some will say, oh, this happens here, and then the scapula kicks in at the end, and this.
So it's an average of 2 to 1?
Yes.
So even though the scapula doesn't kick in until,
Yes,
let's say...
but if you want a definition, for every 2 degrees the humerus moves, the scapula moves 1. If you need a definition.
The bottom line is, if you're treating a patient with just a glenohumeral dysfunction and you neglect to look at the scapula, you're missing the both because it has to work together.
What she said. Everybody got the Bankart Legion correctly? Ate. Yes. I'm sorry? That wasn't a question?
Next.
I was ready.
I took it out. I think I put an easier one.
They're like, did I miss that?
Oh, speaking of, yes, what was your question?
The mind-muscle connection, I mean, the timing issue, could that just be a mind-muscle connection, like, problem?
That could be a what? A
Could be
mind?
Mind-muscle connection.
Neuromuscular connection issue.
Like, I think it's associated with misfirings or not being able to feel the muscle.
A neuromuscular connection?
Mind-muscle.
We said mind-muscle.
Mind-muscle? I don't use mind-muscle ever. I don't know what that means. I'm assuming it's neuromuscular. If it's neuromuscular, it's more of a, not so much a neuromuscular, because there's nothing wrong with anything. It's just a movement pattern. And that is based on what it is that you've learned or what it is you're doing or what, if you carry a kid on your hip all the time like this, then you're going to have external rotation of the hip, you're going to have quadratus laborums, that's just what it's going to be until you stop doing it. And then, but the brain has memory, right? So it remembers that pattern and that pattern becomes normal, so to speak, until we unlearn that pattern. Yeah, so in a sense it's based on what movement patterns you are used to. Yeah. But we're all born with, we all can raise our arm over our head, and unless we have a congenital deformity such as Erb's palsy or something like that. But we all are born with the same amount of movement, and then we learn poor patterns. and then, you know, you have insult to injury, you have CVA or something like that, and then then there's neuroplasticity, or plasticity that needs to occur. And neuroplasticity is just a reorganization of the central nervous system. You know, if I cut off this finger, then the loci for this finger in my brain would be filled with something else, probably this. And they actually did this scientific study with a monkey. They cut off all these fingers and just kept these. So and then they sacrificed the monkey, and they looked on an MRI at the brain, and they saw the parts of the brain that were servicing these fingers are now no longer are gone, and it's been taken up with the area where these two fingers are serviced. So we have neuroplasticity, but it occurs, it's a reorganization of the central nervous system, which takes a lot of repetitive movement. Just like with Christopher Reeves, you know, he had complete severing of C2. Nobody lives with that. I mean, C2-3, I think he did. But usually they have to put a phrenic pacemaker in because your diaphragm's innervated by 3 through 5, right? Right?
Right.
So he had to put a phrenic pacemaker, get off, do frog breathing, and gulp and try to get air into the diaphragm. And they worked with him like 24/7. And he was able to lift his finger. And he was actually able to lift, when they put him in the pool, he was actually able to do a little bit of knee extension. Unheard of neuroplasticity. But they worked with him like 20 hours a day in physical therapy. So do these things happen? Yes, but they're slow, you know. And again, we're talking about central nervous system. But anyway, biceps. We talked about the biceps tears, and we said that the long head of the biceps will tear, rupture, and roll into the arm. So the long head of the biceps comes from where? Supragluteal tubercle, right? Scapulothoracic problems, we talked about the fact that if you don't lift your arm all the way up, I mean, if you have a scapula that's not working appropriately, you only have 120 degrees of flexion or abduction. I asked this question in the quiz, and the answer most of you gave me was winging of the scapula. That is acceptable.
True scapular winging.
Okay, scapular winging, yes. Okay, we saw this, and we said, let's look at this pattern and see what is wrong with this person. And we said it was just because she had large breasts. And she had compression of that, what is that area covering? Where that bra would be covering would be on the suprascapular notch, right? And what goes through there? The suprascapular nerve. So what's the sensory pattern associated with the suprascapular nerve? C5-6, which is the upper anterior lateral arm, right? Makes sense, yes? Oh. Okay. 6 muscles we talked about. I want to clear this up because this morning there was a question about what this exactly means. So if it's a scapulohumeral muscle, it means it's originating on the scapula and it's inserting into the humerus, right? And if it's an axial scapular muscle, it's originating on the axial spine and inserting into the scapula. Right? So some of those muscles you gave me today are axioscapular muscles. And then finally, if it's axiohumeral, it's originating from the axial spine and inserting into the humerus. Okay? Deltoid, these muscles you have. Disorders of the PNS we talked about, which is the worst one? Neurotmesis, will you get any return? You're lucky if you do, because if you do have some, if those little nerve endings do find their way down to the severed nerve, then you might have some return, but probably not. All right, neuropraxia, you've all experienced. Cross your legs, sleep on your arm, have somebody sleep on you. All those things are associated with neuropraxia, as well as Bell's palsy, they say. Sometimes Bell's palsy, though I have seen a therapist actually with Bell's palsy that she's still left with. Bell's palsy is what?
Temporary injury of the face.
What nerve does it involve? Facial nerve, cranial nerve 7, right? And so that person might wind up with facial droop. They can't pucker, they can't kiss, they can't close their eye, they can't wrinkle their forehead, they can't do any of these things. So they might drool from one side, okay? I know a therapist who had bilateral facial palsy and she still exhibits a little lip drop on this side. Remember I said it's transient, it should come back? Everything came back on her except that. She had a bad reaction. Okay. Herpes palsy, we said waiter's tip. Why is it waiter's tip? Because all these muscles that are innervated by C5, 6 aren't working. So our arm is adducted to the side and pronated, and there's no counterbalance between the flexors and the extensors of the wrist, so we're in wrist flexion. Yes? Okay. Bursitis, we said, was a fluid-filled sac, and it's there to protect tendons, and we talked about tendinitis. We left here, right? Tendinitis? Tendinitis, a lot of times, what happens with the tendinitis? Sometimes an overuse injury. So you get an inflammation of the tendon. It's red, it's hot, it's painful. Anytime you do an activity that requires the muscle to pull on the tendon, it's very painful. So if you stretch the tendon, it'll be painful. If you use the muscle, it'll be painful. If you do provocative testing, which is what you guys did yesterday and today, provocative testing will provoke the symptoms. So if I'm looking for a bicep speeds test, I'll push here. If I'm looking, there's other ways to do that too. Jurgensen's test, there's many ways to test the muscle. But I could look to see if it's going to stay in the groove by doing Jurgensen's test. There's a lot of tests. But we're only going to do the most specific ones that you'll see most commonly out there. Okay, so overhead activities, rotator cuff tears. Did we get here? We said rotator cuff tears can be small, they can be massive. And a person can't raise their arm, they can have atrophy. So on visual inspection, they have atrophy, so they have pain, they have muscle weakness. And that's why you take a person's clothes off, all right? Those therapists who bring patients into their clinics and do not take their shirt off when they have a shoulder problem, I think are doing the patient a disservice, because we need to look, especially with the shoulder problem, we need to look at the scapula. So, and we need to note the surrounding muscles. And just because somebody has a shoulder problem doesn't mean that it's not coming from the cervical spine. What do we do if we think it's coming from the cervical spine? We test it, right? So one of the tests that you learned was Sperling's test, because it closes down the foramen on that side. All right, frozen shoulder, adhesive capsulitis, the pain is there all the time, especially initially when it's frozen because of the inflammation. And you'll see an increased activity of the upper traps. Why? Why?
So, compensate.
Why? Why do you think you see an increased activity of the upper traps?
Because you can't flex your shoulder,
So you can't flex or abduct your shoulder. So if I'm going to reach overhead, what am I going to do? I'm going to do this. All right, so I'm moving the scapulothoracic joint, and I'm doing scapular upward rotation. Scapular elevation. So that would be a good test question. Don't write it down. But it'd be a good test question, right? If I said somebody was looking, somebody came into your clinic and they were complaining of pain in the shoulder area, and you noted that they had that adhesive capsulitis, what nerve may be responsible for, not nerve, what may be responsible, what reason would they be elevating their shoulder? Or what myotoma is associated with that elevation, or something like that. So if I said what myotoma is associated with that, you'd say C4. Yeah. Okay. Oh, what does it say? Subacromial impingement, right? Is that what it says on your slide? Subacromial impingement. Most common, you see the subacromial space, and what's underneath that subacromial space? What's underneath that? What's in between that, I should say, the humerus and the acromium? The subacromial space, and what goes through there? Tendons, more specifically, supraspinatus tendon, You can see how it's going to the greater tubercle through that. There's also a very avascular zone there, so it's difficult for healing of this tendon. And you get an abutment of the humerus or the greater tubercle on the acromion. Okay, so rotator, the primary, if somebody's got a primary rotator cuff impingement, subacromial impingement, that refers to a compression. So between the coracoacromial ligament and the acromion, as well as the coracoid process. And when we're talking about that, just give me 1 second. When we're talking about that, we're talking more about something that's decreasing the space. So a primary impingement is associated with repetitive overhead activities, or a hooked acromion, or, because not everybody has, there's different types of acromions. So their space is decreasing. So we're talking about more something, or you have a tendinitis issue, or bursitis issue, or both. Yes?
How would this occur?
How do you get that? Is that what you said? Okay. How do you get rotator cuff tendinitis? Okay, rotator cuff tendinitis would be secondary to overuse of the tendons, and also poor posture, right? So anything that's postural can cause it. A bursa that becomes inflamed, that decreases the space, because remember I'm saying primary impingement, that space is decreased. Okay, so that's a primary impingement. And you can see here that the type 1 is a flat acromion, type 2 is a curved, and type 3 is a hook. So any of these, look what you're seeing here. Is this space increased compared to this one? Yeah. So this is a much larger space than this. If somebody's got a hooked acromion, sometimes they go in and shave the acromion, and they do an acromioplasty. Okay? But I would never get an acromioplasty unless somebody looked at me and made sure that my clavicle, my scapula was working appropriately, and my timing was good. Yes?
This would be, you would be born with the shape of the. this
Yes,
can't
you're
change
born
it.
with it.
Okay.
You're born with it. Okay, secondary impingement could be related to glenohumeral instability. Also, these muscle imbalances. So again, it could be timing issue as well as muscle imbalances. So that humeral head may elevate. Why will the humeral head elevate and minimize the space between the acromion and the greater tubercle? Why? I said it a million times. Why? Chris?
If the rotator cuffs are weak and the deltoid is doing too much.
Absolutely. So the rotator cuffs aren't doing their job with keeping the head stabilized in the humeral and depressing the humerus, and to counteract that overbearing pull of the deltoid, to pull it up with superior migration into the acromion. Yes. Okay? So impingements can also, you can get an irritation, you can get bone spurs, you can get calcific tendinitis. Anything that's going to decrease the space is going to give you an impingement. Postural problems. So the supraspinatus, long-headed biceps, subacromial bursa will be most effective in these primary impingements. You'll get a painful arc of motion. What does that mean? When somebody lifts their arm up, what they're looking to do is they're going to look to try to get that tendon out of the way so they don't compress it, right? So they go up to here and then they start to wiggle it around. So they'll have normal range of motion between 70 and 100, well, when we get to between 70 and 120 degrees, they start to move their arm around. So they'll do this. Yeah, I could lift my arm over my head, and you see a painful arc of motion, okay? Because they don't want it, because it becomes compressed and it becomes painful. So you'll see it in young people, and they don't realize how they got it. It can occur in young people. When it's recurrent in people that are around 20, 25 years old, it can become fibrous, and it can become fibrotic and not glide properly. And then by the time you get stage 3, you can have bone spurs. Bones lay down in lines of stress, and you can have some bone spurs, and the tendon can rupture, as well as with postural problems, right? So as you start to lean forward and as you start to keep lifting overhead, what's happening? As you move that whole scapula forward, you're decreasing that space, aren't you? Yes. So as you're leaning forward like this, you're in internal rotation, or the scapula is internally rotated, it's gonna cause you, every time you lift your arm, to hit the tendon. And every time you hit the tendon, the repetitive motion is gonna cause a shearing effect, and eventually it may rupture.
Tightness of the pec minor anterior tilt, would that cause a reduced space as well?
Yes,
If the scapula is tipping forward?
yes, yes.
That the other thing.
And it's also gonna cause, and the pec minor and overactive pec minor will also cause you to be in more downward rotation. So that'll prevent the upward rotation, which is more of a timing issue. Okay. Glenohumeral instability. Yeah, take it off. Glenohumeral instability, we can see here that the head of the humerus will move in an anterior direction. There's a lot of movement here. So generally, with dislocations, when they occur most commonly like this, in an anterior direction, right? Through the anterior capsule. Thoracic outlet is a neurovascular compression. So neurovascular compression meaning that it involves nerves as well as some vascular structure. The vascular structure involved is the subclavian artery. So subclavian artery is here, and then eventually becomes the axillary artery, goes down to the arm, etc. So subclavian artery may be caused from a cervical rib. Should not have cervical ribs. The ribs start at the thoracic, are connected to the first thoracic vertebra, right? So if you have a cervical rib, you could have neurovascular compression. You could also have that for pec minor tightness, poor posture. There's a lot of things that cause you to have thoracic outlet. Okay, so the treatment is we got to get some postural correction. Pec minor tightness can also give you thoracic outlet, so TOS. So what's the test associated with TOS? I ask a patient, because the patient, what is this patient going to complain to you? She's going to say, my arm is heavy and I feel tingling and numbness in my hand, right? So we ask her to elevate both arms, 90 degrees, 90, and we ask her to open and close her fingers. And we do it for 60 seconds. And we watch. We watch for heaviness of the arm. We watch for the inability to do this. We watch for repetition of symptoms. We watch for pain. We watch for whatever she's going to tell us, okay? So she may do this and then she starts to get fatigued. Why does she get fatigued? Because she's compression of the subclavian artery, okay? So you hear a lot of people who maybe are hairdressers or something, or some people that do a lot of activities up here, and they come in, and what are they doing? They're closing off. Where's the brachial plexus line between the clavicle and the first rib? You're closing that off constantly. So you're compressing that brachial plexus as well as that subclavian artery. Okay? So what do? We do postural corrective exercises. We do pec minor stretches. We do whatever needs to be done. If it's a timing issue, we work on that. Okay? Brachial plexus lesions. They could have sensory loss over one finger, two fingers, any of the fingers. Brachial plexus, when they turn their head to the opposite side, sometimes they stretch the brachial plexus and they have an increase in symptoms. So if she does this or she does this, she says, oh, now I really feel it. Okay, and at that point we would teach her nerve gliding exercises, which we haven't talked about yet. So here's the thoracic outlet. You can see the clavicle, the median nerve, subclavian artery, and the scalenes. So tight scaling muscles also contribute to thoracic outlet syndrome because what do? They elevate the ribs. All right? So Ruiz test we just did. There's different diagnostic tests. X-rays are for bones. Osteophytes, bone is laid down in lines of stress, right? So osteophytic formation will occur with bones, especially after you break a bone, but may not necessarily be in the right place. So you can get osteophytes. They're painful. CAT scans are specific for bones. MRIs, you can have with contrast or without contrast. They're good for soft tissue. Angiography is they do this into arteries. They inject contrast material. Myelographies, X-ray with contrast dye into the subarachnoid space. So they look for, you could look for discs with this. EEG records brain activity. Nerve conduction velocity studies look for nerves, axonmesis, etc., neuropraxia. and arthrograms injects the dye, it's more specific, and then we do have some pictures. So an MRI, anatomy of the shoulder, again an MRI. What's this?
That is the circle.
Circle Willis, you can name these things, right? Oh, they're named. So, what would this one be? Vertebral artery, right? Basal artery, what's this? Posterior communicating, anterior communicating, middle cerebral. Posterior what? Cerebral.
Where do strokes occur most often?
Middle
MCA.
cerebral artery, right. Okay, CAT scan, look at that bone. Angiogram, again. That look familiar? But it's an angiogram, so we're looking at the vessels. Arthrogram of the shoulder, you could see more specific. What are we looking at here? We're looking at something on the greater tubercle, right? So what do you think that is? Supraspinatus. Supraspinatus. And a myelogram. What do you see right here? What do you see?
HMP.
HMP at T6-7, unusual. But that's
Very
an
unusual in
HMP.
thoracic.
That's an HMP, thoracic spine, between T6-7.
Would that be thoracic probably related, or?
I don't really know what this was, but it's unusual.
Could be trauma.
Yeah. Okay, so Near's impingement sign. You guys learned this? Stabilize the arm. Let's put you this way. No, go this way. Stabilize the shoulder. Internally rotate the arm up. Overpressure, right? What are we doing? We're closing off the area. We're causing an impingement to occur. Okay. Scaption plane of scaption. Right? Impingement. Positive impingement sign. So we do both. Gerber's test or subscapular lift. Inability to lift their arm off with resistance, right? Positive. There's also a bear hug test. So patient puts their arm here, and I usually do it two ways. So I'm doing it this way and this way. Some people just do this. Pull the arm off. So she's in internal rotation. I'm taking her into external rotation, right? Provocative testing. So I have a 2-point hold here. One here, one here. Hold, don't let me move you. Okay? So 2-point hold. Belly press test again. Subscapularis integrity. Put your hand on your belly. Hold. Hold. Okay? I don't know if you guys went over that.
Yeah, we can go down.
Biceps tendon. Positive test. Hold here. Hold, hold, hold. Pain. Inability to hold. AC joint. Passive adduction past 90 degrees. Pain. Elicits pain at the AC. Okay. Do we have any time? Okay. So I'm going to cover a lot of the hand, and I'm going to finish the elbow and the hand next week. And then probably the week after we'll have an exam. Okay?
We don't have an exam this month.
Well, you have a muscle exam.
No, muscle press, yeah.
Yeah, but you'll have a 50-question exam next week,
We have a motion.
Real quick, is it,
Tuesday and Thursday.
Yes.
you want me to send out,
Yes. Also, there's going to be a triceps and anconeus.
Ask her. Not sure.
Lindsay sent triceps and anconeus. That will be on the test next week too. Okay. So those of you who want to read further, because you're caught up now. If you're not caught up, please
Please catch
reread
up.
this. And if you are caught up, then you want to start the forearm. Okay.